This is Tom Lee, editor-in-chief of NEJM Catalyst, and we're talking today about GLP-1s with Sarah Iman, who became president and CEO of ICER, the Institute for Clinical and Economic Review, after several years as its COO last year. ICER is a hugely important source of unbiased analysis of the value of pharmaceutical agents, and they will be issuing a white paper on policy options for ensuring affordable access to GLP-1 medications on April 9th. Sarah is going to discuss some of the key conclusions today. Now, before we start, a word about conflicts of interest. Now, Sarah doesn't have any, but I realize I should mention two of mine that are relevant. First, as a primary care physician and cardiologist, I prescribe these drugs a lot. Second, I'm on the board of directors of two health insurance plans, and both are really, really, really challenged by the costs of the GLP-1s. My conflicts reflect what everyone in the audience knows, and we won't take time recapping this today. First, that these drugs are a marvelous advance with benefits that probably go beyond what we already know. And second, they are currently so costly from a budget impact perspective that society cannot afford them for all the patients who might benefit. So we're going to talk with Sarah and see what she and ICER think are our options. Now, before we get to those options, Sarah, can you tell the audience a bit about what ICER does and how it developed this report?
Absolutely. Really appreciate being here with you today, Tom. I think that for those who aren't familiar, the best way to describe ICER is a health policy research organization. We are dedicated to using evidence to help us know how much better a new drug or a new procedure or a new medical device is, and then how much we should pay for that benefit that it's bringing patients. This is known internationally as health technology assessment. We do reports every year on new drugs right around the time of FDA approval. But also each year, we gather together the leaders of big pharmaceutical companies, big pharmacy benefit managers, and big health plans to tackle some issue that's keeping people up at night. Last year in 2024, our paper was on how to pay for gene therapies. This year, our paper is on how to pay for GLP-1s.
Well, now I'm skipping past the truly first-rate review in your report. You were kind enough to send me an advanced copy. And the background for this discussion is there, and I would encourage readers to go look for it. How the drugs were developed, how they were brought to market, the pipeline, current coverage patterns, and financial impact. But the question on my mind for our discussion today is, what the heck do we do? So I'm skipping to page 16 of the report, where you begin describing potential market strategies. Now, you list several, and I think each of them deserves some description and some comments by you. Can you start with the first, temporary coverage denial?
Absolutely. This is probably everyone's least favorite, including the people who are implementing it. This is the idea that we restrict access to the GLP-1s to only certain patient populations. So right now, they have a pretty broad label. People with obesity, people who are overweight, maybe with a comorbidity. Sometimes people think of this as a particular BMI level. But what we're seeing from some of the plans, the PBMs, and the purchasers themselves is thinking about restricting access to people who have the most potential for biggest benefit. This is very similar to what we saw with the introduction of the hepatitis C medicines back in 2014. Because there were so many eligible patients, because the drugs were expensive at the time, people were saying maybe only those who have advanced disease should get access while we figure out how to make it more affordable for everyone else. So temporary coverage denial could be don't give access at all, or only give access to people who might have a BMI over 40, say, or have a BMI of 35 plus a comorbidity. This doesn't feel great. I'll tell you, we put it in the paper because it's happening. Most of the people we spoke to for this paper said they do think this is temporary while we figure out other options for making these drugs more affordable for the system and for patients. But temporary coverage denial is absolutely something being considered by a lot of plans.
Yes, and I think we're going to see more of it as the year unfolds. So let's think about the other tactics that might be employed. The second on your list is enhanced prior authorization and formulary management.
This is a building on the temporary coverage denial. So if temporary coverage denial is you can't get it at all, or it's only for certain patients with a particular comorbidity or particular BMI, then prior authorization and formulary management can be another way to try to control costs. So using utilization management to say only certain patients with a certain BMI with a certain comorbidity, but also formulary management, meaning I might only prefer or have one of the GLP-1s available on my formulary, and that might help me get a bigger rebate from that manufacturer to make the drug more affordable for my plan. And that means you can only get one of the two drugs, depending on who gives them sort of the best deal. I think this is another area where we have seen this approach in other conditions for a large population with a maybe cost-effective from a long-term value perspective drug, but a one that represents a big budget impact problem for purchasers. So this can also be something that's done temporarily while the market continues to work, while we might see prices come down over time. But this is the idea of you only get access if you meet certain criteria, and we might only have one of the two drugs available on our formulary.
Okay, Sarah, so far you're not making many people happy. Uh, let's go to,
Right, that's true.
let's go to the third option, provider network management.
This is the idea that only certain providers could be allowed to prescribe it. Now, you'll hear, and we did hear this in our interviews with stakeholders and experts for this paper, that the GLP-1s as a class have been out for a really long time and been used for the management of diabetes. So pretty much everybody's in the clinical space has experience with these drugs. You made reference to that in the beginning, but primary care physicians have a lot of expertise in prescribing these drugs. But we also heard that because these drugs used for obesity are at a higher dose, which sometimes can come with more side effects, we heard from some who said, we've had success limiting the ability to prescribe these drugs to obesity management specialists or to centers of excellence because they also offer important wraparound services for lifestyle management, for managing the side effects, and maybe even starting patients on other therapies before getting to the GLP-1s. There are other drugs approved for weight loss. They're not as effective, but they do work for some patients. So this idea of managing the network by limiting who's allowed to prescribe the drugs is a way to ensure the drugs are getting used for the most appropriate patients, and those patients have the best experience possible, again, managing their side effects, doing the dose titration, whatever it might be, in order to get the best results. But on the other hand, you're right, I'm not making too many people happy. This isn't sort of broad access that we would want necessarily for patients who qualify for these drugs because there are a limited number of obesity specialists in the country.
Okay, fourth is innovative payment arrangements.
And this one, we had a robust conversation with our stakeholders about this and the different leaders of the organizations who are in the room with us. Like I said, biopharmaceutical leaders, health plan, and PBMs. A lot of times you think about innovative payment arrangements for something like a gene therapy, where you have a one-time therapy and you're expecting a long time of benefit. Okay, well, what happens if that benefit wears off? I've already paid for the therapy. So something like an outcomes-based contract makes sort of intuitive sense when we think about something like a gene therapy. But in this case, this is a chronic therapy, something people take every month, potentially for their lifetime. That's a little bit of an asterisk, open question about the benefits of these drugs over time and whether or not they can be stopped, but we don't know that now. So right now it's imagined this is a chronic therapy that you would take for your lifetime. And so we're not sure an outcomes-based contract is really the right idea here. The other thing is outcomes-based contracts are really good when you have uncertainty about the benefit, but as you acknowledged, everyone's pretty sure these drugs work really well. So that's not where we have uncertainty. However, what they do represent is an opportunity, an innovative payment arrangement to give budget certainty to a payer. So a payer is is freaking out right now because they can't plan for how many patients might take these medicines and what that's going to do to their premiums and their costs. If you had budget certainty, something like a Netflix model, which we've tried with hepatitis C drugs, that could be a way to ensure universal access for your members, but in exchange, you have some certainty about your budget. So perhaps it's a fixed amount that you know that you will pay for a year for as much GLP-1 as your providers can prescribe. That at least gives you certainty to plan for your premiums, to plan for maybe there's other parts of the healthcare system or your healthcare spending that you want to address to make headroom for this high value spend. So those are some of the ideas that people bandied about for the innovative payment arrangements. On the downside, people are like, innovative payment arrangements come with administrative cost. And we're not looking to add costs right now, right? We're really looking to try to streamline costs. And so I think it's an option. I think it might work for some purchasers, but we'll see. We haven't seen anyone take this up yet that I've heard.
Now, fifth is carve-out programs for obesity management services.
This was really fascinating because it dovetails with the intersection of the rise of digital health therapeutics. So a decade ago, we weren't really talking about the fact that there are disease management applications you can have on your phone. There are devices that you can wear that can tell your clinical team how you're doing with different conditions. But here we are. We've got digital health therapeutics rising. This carve-out program idea, many of them combine some of the elements of a digital health program, whether it's telehealth or remote monitoring, an app-based algorithm to help you manage your lifestyle or adjust your diet or even manage your side effects on a new medicine. And they've carved it out specifically for obesity management. What we've seen, early results, definitely need more research here to know how successful these will be, but we have seen a successful implementation of these programs for certain purchasers that are allowing patients to reach their goals for achieving weight loss, but doing it maybe on some of the older meds, reserving the newer GLP-1s for those who don't have any benefit from some of the older therapies, having access to counseling, to peer support, all of these wraparound services that they can offer as a carve out to purchasers is proving beneficial for some purchasers. The other thing I'll say about carve-out programs is it's something that you as an employer purchasing health insurance and health care for your members can directly contract with some of these programs. So instead of going through your PBM or through your health plan, you're carving this out and offering a select service for patients and your employees who qualify. This is one I am really fascinated to watch to see how successful it can be. Like I said, early results, really positive, maintaining weight loss, having lower PMPM per member per month costs than some of the other health plans and others who are trying to provide access to these therapies. I'm really going to watch this one closely.
Now, the final section of your report describes potential federal policy interventions. Do you have any read at this point on what the Trump administration might be thinking about how to control the cost of GLP-1s?
I don't think anyone knows, but I will venture a few hypotheses about where we might be headed. We have at the intersection of some long-held and honestly quite stigmatized views of obesity intersecting with a new class of medicines that are delivering transformative benefits for patients. And those things are coming to a head. So specifically, Medicare and Medicaid, well, Medicare was not allowed to reimburse medicines for weight loss because it was considered cosmetic. It was left up to each individual Medicaid department to decide whether or not they would cover them. So this has created a lot of inequities in access because if you are on Medicaid, your providers are not allowed to prescribe this for you and then have it be reimbursed by Medicare. The Biden administration reinterpreted a rule towards the end of its administration saying, nope, actually, in fact, we can have Medicare and Medicaid cover these medicines because this is how we're interpreting this particular rule. Now, as you might imagine, because of the budget impact calamity that is being felt by many health plans, several health plans have gotten together to say, wait, I don't think you're allowed to reinterpret that rule. We don't think you should make us cover these medicines, at least not without giving us some money to do it. I think we think that it is up to each plan to decide how to manage access to these medicines. So far, the Trump administration has not tipped its hat on whether or not it thinks that reinterpreted rule needs to be revisited. And we also have conflicting public statements from some key advisors in the Trump administration that are worth watching. We have heard that RFK Jr. doesn't think we should be investing in GLP-1s, we should be investing in healthy eating. Whereas Elon Musk has talked openly about how much success he's had taking a GLP-1. So this one's anyone's guess. I do think there's a lot of public support for giving access to these medicines because public support has really evolved to understand that this isn't a lifestyle choice. This isn't a willpower issue. This is a disease. And to have a successful, effective treatment for something that has been so tough for so many people for so long, I do think that public opinion is swinging towards access to these medicines. But I think what we really need to focus on is whether or not we can have a system that can afford these while not driving up health insurance premiums for everyone.
Well, what an incredibly interesting and complicated set of dynamics. Now, Sarah, as Yogi Berra said, it's hard to make predictions, especially about the future. But I think we should give a try. My take is that these are great drugs that are going to become as ubiquitous in our lives as statins are, and that the price will be driven down by competition among multiple options. Do you agree? And if so, any guess on the time frame to when that might happen?
I really want to be optimistic here and think that we might have a situation similar to the introduction of the hepatitis C drugs back in 2014, when we had drugs that looked like a fair price from a long-term value perspective, but really were representing a huge challenge from a budget impact perspective just because of the number of eligible patients. And what we saw was competition drive down the cost of those medicines and made them more affordable. However, I've been watching this space for a long time, and guess what? We didn't have competition bring down the cost of medicines for rheumatoid arthritis or plaque psoriasis or multiple sclerosis. So which one will this be? Will it be the hepatitis C example where more competition, and my goodness, the pipeline is full right now of compounds that want to be playing in this space, GLP-1s, other mechanisms of action. Will we see that, the competition drive down the cost? Or will we see what happened for RA and psoriasis and MS, where we just saw prices actually go higher and higher, even with the introduction of new medicines? My feeling is because very few people have ever walked into their office and said, hey, please, can I go on a statin? But we do have a situation where people are walking in, talking to their doctors saying, hey, are these drugs right for me? Then I'm cautiously optimistic that with the introduction of 2 or 3 more competitors, maybe in the next 2 to 4 years, we will see the prices come down and we'll see more affordable access for everyone.
Well, Sarah, I hope you're right. I think your optimism is actually blended with real knowledge, and I just want to thank you for sharing your insights today. The report is fantastic, and I think that a lot of people are going to learn more about ICER as well as the GLP-1s from reading it. So I also want to thank you and your team for the great work they do, and I hope that you can bring more of the insights that come out of ICER to the world through NEJM Catalyst in the months and years ahead.
It's been a pleasure. Thank you for those kind words, Tom. Really excited to share these insights with your audience, and I can't wait to come back again.